Good afternoon, everyone, and welcome to our stakeholder reference group. This is a live Q&A session, and I hope by now you've all had a chance to have a look at the PowerPoint slides. So we're just waiting a couple of minutes. I can see a couple more people are just joining us. So I think we're a full house. We are running this session again tomorrow. So you've met me virtually before. My name's Louise Halfpenny and I'm the Director of Communications. And this session, as you know, is on Zoom. We will have you on mute during the presentation, and then we'll use a mixture of the chat function and also raising your hands to let us know that you've got questions. We will try to come to you in order, and we already do have a list of questions that have been submitted. So we're going to start with those questions immediately after the presentation, and then we'll try and be as democratic as we can and fit as many questions in as we can within the hour. So with us today we have Dwayne Passman, and Dwayne, as you know, is the Acute Redevelopment Programme Director. And just to give you a run through of the aims of the session, it's to just give you a brief history, which some of you will know a lot about, but there may be those out there who are joining us for the first time. So we'll just bring you up to speed. Then we're going to talk to you about the programme timescales, to give an overview of the decision that the boards of this organisation, West Herts Hospitals Trust and Herts Valley's Clinical Commissioning Group made on the 1st of October, and then we're going to outline the next steps. Now, before I hand over to Dwayne, I should say that I've seen that one of the questions quite rightly has picked us up on the use of acronyms. So, Dwayne, I'm going to ask you when you do present if you can remember the HMTs, the SOCs, the OBCs and the NHSIs and Es. If you can bear to explain who those people are or what those acronyms mean, that would be really, really helpful.
I will.
So, thank you. So next slide, picture of Dwayne and I, and then off we go over to Dwayne. Thank you.
Thank you very much, Louise, and thank you all very much for making your time available today to join this presentation. As Louise said, I'm Dwayne Passman. I'm the Acute Hospital Redevelopment Programme Director, and I started the Trust in July. Some of you I've met virtually before, others I won't have done, and I apologise for, in the circumstances that we're in, not having the opportunity to meet you directly. So just the background, and I've been around for 4 months. You will know far, far better than I the history of the proposed redevelopment across West Hertfordshire. There's been, over the last 20 years, a number of different proposals, particularly up until the global crash in 2008-9, to secure funds for the redevelopment at Watford, but also across the rest of West Hertfordshire at St Albans and Hemel. In 2017, we put together a strategic outline case that looked at how we would redevelop our services across 3 sites, then refreshed that in 2018, and we were given at the time a upper financial limit of 350 million. And why that was the case was the rule of thumb from our regulators. So NHS E&I, NHS England and Improvement, when they were separate organisations, and the Department of Health and Social Care, DHSC, and HMT, the Treasury, had a rule of thumb that said you couldn't invest if it went above the level of the turnover, i.e. the amount of money that came into your organisation. You couldn't invest more than that across your 3 sites. Now, in over 2018 and 2019, that did change. So in 2019, as you all know, we were named as one of the 6 new hospitals in the health infrastructure programme in wave 1 of that programme. And broadly speaking, about 400 million was allocated to West Hertfordshire Hospitals Trust to pursue its redevelopment programme. During 2020, we were asked to look at other options that might exceed the 400 million, particularly replacing our main clinical block on the Watford site, the Princess Michael of Kent wing. Now that, as I would say, is not guaranteed. That is not guaranteed, and we have to make the case for it. And that's the final point on this slide, is that what we will have to demonstrate is that any increase in investment that we make over the 400 million is backed up by the benefits that we can accrue, that we can take, either as an organisation or societally, to deliver the best value for money. So if we're spending £1 and we get £4 back in terms of benefits, we need to be absolutely sure that if we spent £2, we can still get £8 back, and that we can deliver everything that we've said by 2025 or as soon as possible thereafter. And that's been very, very important to us in terms of setting out our investment objectives and our critical success factors that we've talked through in previous presentations. And if I could have the next slide, please. Those are our project milestones. I don't intend to look back too much on this because we've already looked at that as part of the previous slide. In October, at the beginning of October, we did approve with our partners at Hearts Valley CCG a short list of options, 6 for emergency care and 3 options at each of the sites at Hemel and St Albans for how we would develop services there. That's the point we've been to over the next couple of years, and I'll come to that in later slides, is that we do have still an enormous amount of work to do to deliver a full business case, to appoint a contractor, and to create a new hospital and refurbished facilities and new build at our other 2 sites by 2025-26. And our commitment to everyone on this call today is that we will continue that stakeholder engagement in different ways, and I mean at different levels of how we look at the new hospital development over the next few years, all the way through until we open the new facilities and then beyond. If I could have the next slide, please. So, sorry, excuse me. We were looking, what we've focused our attention on at the moment, and this came out of the strategic outline case in 2018 and 2019, was focusing our attention primarily on emergency care. As many of you will know, emergency care represents 80-odd% of the overall activity, the overall number of patients that come through our doors every year, year on year. So it's been our biggest priority because it's the biggest number of patients that are affected by any proposed redevelopment, to focus our attention on emergency care, but also, as importantly, on planned care and how we can enhance planned care across the whole of West Herts. We've followed the HMT, Her Majesty's Treasury appraisal process, and that's governed by a document called the Green Book. And one of the earliest presentations I did when I joined the Trust was to talk about what the Green Book was looking for. And the Green Book guides all the processes that we need to go through as a public sector body, and this is the same across government, for how we propose to spend money on our infrastructure. And that was approved by the Trust and our partners in the local clinical commissioning group on the 1st of October 2020. Now, during the summer, We looked at our investment objectives and critical success factors, which were set out in the strategic outline case, and amended those following stakeholder feedback and input. And those were presented in that pack that we took to the joint boards on the 1st of October. As we sit here at the moment, the cost of the preferred way forward is about £590 million at today's prices. And that's split, broadly speaking, between about 540 million at the Watford site and about 50 million split between St Albans and Hemel Hempstead, as I said in the final point there. If I could have the next slide, please. Now, as you will know, our preferred way forward, and I do know, and I am mindful and respectful of the fact that our preferred way forward is a new major clinical facility at the Watford site, and that will not be the preferred option of some of the people on the call, and I am mindful and respectful of that. We are looking also to include land currently owned by Watford Borough Council, just further down the hill from the existing site as part of the Watford Riverwell development. And picking up the third point there, looking at how we can integrate a new major hospital facility alongside the planned regeneration of the Riverwell area in Watford, including green space, coffee shops, restaurants, leisure facilities that not only local residents can have access to, but our patients, visitors and staff can have access to as well. Now, the preferred way forward that we've been talking about, both for emergency care and planned care, does include making improvements to urgent and planned care services at Hemel and St Albans as well. Now, I know that through the consultation and survey process that we've been through, a lot of people are very, very concerned that there will be a great deal of disruption and noise, dust, vibration from building works on all three sites. Now, what I can say, picking up St Albans and Hemel, is our local estates and facilities team are very, very skilled, and over many years have undertaken refurbishment projects, major and minor scale, at St Albans and Hemel Hempstead, and have been able to ensure that there has been a minimisation of disruption to existing services on those sites. And we will use that experience on that site to make sure that the same is true of the work that we do at St Albans and Hemel. In terms of Watford, I would remind everyone that the majority of major hospital redevelopments in this country for the last 50, 60 years have been undertaken on existing sites. And there are well-defined ways in which we can minimise noise, dust and vibration. And we will also have to work with Watford Borough Council, because they will put very, very strict limits on us as to what impact we have on surrounding areas for local residents while we're building a new hospital facility. And I've been involved in major hospital facilities for over 30 years, and that is a well-defined series of things that we can put in place. So around segregating the site, making sure that there is noise and dust and vibration monitoring on site to ensure that it doesn't exceed very, very strict external limits. And we will make sure during this that we're very, very careful about the way in which contractors work on the site, that they're respectful of the site, that they're respectful of local residents, and how materials are brought to the site as well. Could I have the next slide, please? Our preferred way forward in more detail. Watford would be developed as the, pretty much as it is now, emergency and specialist care services in new buildings, acute medical and surgical assessment, inpatient medical and surgical beds, emergency surgery, critical care, new women and children's services, and a wide range of diagnostics. That would mean during that build that the majority of inpatient beds would be in single occupancy rooms. Now, exactly the proportion we haven't yet defined. It will be between somewhere between 50 and 80% of single occupancy rooms, but 90% of the buildings on the site would be new, and there would be a small amount of refurbishment or moving some services like offices off-site to take advantage of the other facilities that are around us. Hemel, we will continue to provide urgent treatment, women and children's services, diagnostic and outpatient services. But what we're going to do is focus on medical specialties and particularly long-term conditions. Things like asthma, COPD. I'm a long-term asthmatic, so I understand the real strength of having a dedicated facility to look at long-term conditions. A new urgent treatment centre, more diagnostics, and concentration of specialist diabetes and dermatology on that site as well. At St Albans, at the moment, that's our COVID-free site, and we plan to further enhance our planned surgery facilities there, and also a rapid access cancer diagnostic centre and increase the range of diagnostics available, including more investment in CT and MRI, so computerized tomography and magnetic resonance imaging. If I could have the next slide, please. So it's been a long path to get to where we are. We've got a lot more to do, and this reflects what we've got to do by the end of this year. It's a long list. Continue to engage with you, and particularly staff, on transport and access. That's a really, really important thing for us that was highlighted in the survey that we undertook in September. And we've heard that message very clearly, and we will set up some special sessions around transport and access. We'll also look at ward layout and design principles. So how we're actually going to plan the hospital in detail. What one of our ambitions is to expand the membership of the Stakeholder Reference Group and make it more inclusive, more diverse, to reflect everyone across West Hertfordshire. We're looking at demand and capacity assumptions at the moment. I have a meeting immediately after this to go through that in some more detail. We also need to understand how much it's going to cost to run our new facilities and the benefits that we take from that, the benefits that we take from redeveloping the hospital as much as we possibly can to ensure that for every pound we spend, we're spending it wisely and we get £4 back in terms of those benefits. And we need to do that for each of the options that we're looking at in the pack that was contained and discussed and agreed at our boards on the 1st of October. We're currently looking at how the big jigsaw puzzle fits together. So on each of the sites, how we put together the different building blocks to get the optimum adjacencies, where departments sit next to each other, that will provide the best outcome, the best travel distance, the best experience for patients, visitors and staff. To then go to the level below that and to understand how many rooms we need to make sure that that happens and how much it's going to cost. We've started enabling works for our new multi-storey car park at Watford, and that's due to be complete in 2022. And we will be looking to approve a preferred option, not just a preferred way forward, but a preferred option as to what we're going to build by the Trust Board and the board of the Clinical Commissioning Group in February 21. Could I have the next slide, please? that will allow us to complete what's called the outline business case. The outline business case is the middle part of the process that we're going through. We've been through the strategic outline case, which is at very, very high level, looking at what we kind of want to do in strategic terms. The outline business case puts more flesh on the bones of that. So it looks more tactically about how we could do it. And that includes what benefits we realise, both in financially and non-financially. And what I mean by a non-financial benefit is things like improvements to outcomes for patients. Outline plans across the system, financial and service transformation. Now, I know that this is all jargon, and I know it's difficult for a number of people outside the health service to kind of get this. Service transformation means how we're going to do things differently. So how we will work with our partners in the clinical commissioning group, in primary care, in community care, in social services, in the voluntary sector as well, to ensure that we've got everything interlocked so that we can make sure that if people don't need to come into hospital, they don't have to. They can be treated in the community or somewhere else. Equally, if they do need to come into hospital, they can get through the process as efficiently and effectively as possible. We've also got to lay out what our project management plans are to get us through the next stage, which is the so-called FBC, the full business case. And I'll talk a little bit more about that in a moment. And also how we make sure that when we're looking at electronic patient record, the EPR, and our digital plans beyond an electronic patient record, how the build and that level of technology can work together to make sure, again, that we provide the best patient experience and that we can have the most efficient and effective hospital possible. And during that process, appoint a construction partner, someone who can work with us to actually build the building finally. And if I could have the next slide, please. The so-called full business case, the FBC, is the final step in the process. This gives us the final go-ahead to go and build our new facilities, but also, as importantly, to make sure that we have the confidence across the whole health system with our partners at the CCG and with other healthcare providers, that we can start working through exactly how we're going to work together in fine detail to make sure that all those benefits that we've set out, all the things that we can get from this new investment can be realised, both financially and non-financially. Project management plans for implementation, so how we're actually going to work to make sure that all those plans that we put in place can be realised, and who's going to be personally responsible for doing it and how we're going to measure it. Detailed financial models, so again, how we can demonstrate that we're getting the best value for money out of the public purse, and how as an organisation we can ensure that the money we spend, both in capital terms, so in the building, and how we staff the new hospital facilities are the best they can possibly be and are affordable to the NHS. Final price from our construction partners, so really nailing down how much it's going to cost to do this. And to complete our multi-storey car park, that, as I said earlier, is already, the enabling works for that are already on site, and we want to finish that in 2022 and relocate some of our pathology services off-site. And what I mean by that is, it's those routine pathology services that aren't absolutely urgent to be reported on absolutely immediately. So-called cold pathology services, moving those off-site. And that's a trend that's been around in the NHS, gosh, for nearly 30 years now, to relocate those kind of services off-site, while making sure that we have on-site, on our sites, and available to all our hospital sites the ability to turn around quick pathology services, so-called hot pathology services, when we need them, to make sure that we can make a rapid diagnosis and treatment for patients who come into our hospitals on a daily basis. And if I could have the next slide, please. Thank you very much. That's our website. I hope that has been in some way helpful. I know we've got some questions from many of you who've submitted them earlier, and I hope that there will be an opportunity then to take other questions in person as well. So thank you very much for your time. Thank you for your attention, and look forward to talking to you in just a moment.
So thank you very much, Dwayne. Thanks for going through all that. So yes, as you said, there are some questions that have been submitted before. So we ought to, because people have been kind enough to send them, to get through these as quickly as we can. And if you don't mind, I'm going to paraphrase just for time. And the first question, which I'm also happy to address the first few, is about specialist ophthalmology, and will those services continue on the Watford site? And the questioner also wants to know, will they be upgraded? So to address ophthalmology, I would say that we have no intentions at the moment to move the specialist aspect of this service off the Watford site. What we have been doing over several years now is moving services out into the community, and we have around 5,000 appointments now in the community, which are provided by community health eye care. So it's a model that we're using across many different services. So the acute end, the most specialist end of that particular service, is provided at a hospital site where we have the facilities that you may need, and the less acute aspects are provided. For instance, community health eye care have some premises in the Intu Centre in Watford, and I think elsewhere in West Hart, so away from hospital sites. And will they be upgraded? Absolutely. They're in a part of the estate now that we expect to be one of the first victims of the bulldozer. So it's not really about upgrading, it's about demolishing for some of our buildings, quite a lot actually. So we expect that service to have much better facilities in the future. The same questioner asked about the My Care record, so patient record. Really brilliant question actually. Does My Care record include provision for recording the preference details of the individual advance directives? And these are also called living wills. So I don't honestly know the answer to that question, but we are developing the electronic patient record over the next few years. And so it is definitely something that we will look to build into the electronic patient record as it develops. So thank you for that question. And I will also make sure. Yes, hello, John, are you out there?
Yes, thank you.
Yes, go for it.
Because I use My Care record as well through my local GP practice. Not all of the functionality, and it depends where you are in the country, for My Care record is enabled yet. So on my Care record, it's more around what my regular prescriptions are, so that I can reorder them automatically. And also when I've got appointments, there isn't anything more on yet. So something like an advanced directive, I can't put onto My Care record locally yet. It's worth a discussion, and this is the discussion I had with my colleagues in IT, because My Care record is held by your local GP practice. If you can have that discussion with them to see if the functionality locally is available, and that would enable you to do that. Now, as Louise said, what we're looking to do at the whole of the system level, so across West Herts and North Essex as well, is to look at how the electronic patient record interacts and interfaces with care records from social services and also from GPs. So the feeder system, the way in which that would get flagged up if someone came into hospital, if they had an advanced directive, is twofold. It's either through my care record, and you need to discuss that with your GP practice to see if that is available, or if someone came into hospital who had an advanced directive, it's to make sure that the staff in hospital are aware that that advanced directive is there, and to have that conversation with clinical staff. Now, I know that sounds a bit waffly and a little bit awkward, but at the moment, as we sit here today, that's the way it works. So my advice would be, if you've got something like that, please discuss it with your GP practice to see if that's available within the existing My Care record.
Thank you, Dwayne. Thank you for that clarification. There is a question here, which I'm going to start, Dwayne, but I think you've probably got more knowledge on this. And it was a really good question about the increase in the percentage of single rooms, which is something that we really want to achieve. And the questioner says, surely that will require higher safe staffing levels than currently. And as the NHS is currently short of staff, what will the estimated increase in staffing be for single rooms, and how will we recruit? So my understanding is that with the use of technology, for those patients where you just need to keep regular observations going, that a lot of those can be done automatically, and that information pads are on the outside of rooms and they are hooked up to different systems. So if anybody is going above or below the measures that we expect for that particular patient, then a nurse would go in and see them. So we will be using a lot of technology to keep patients safe. Obviously, for some patients, they do need more one-to-one care, but we do hope that by embracing all the advances coming down the line and being used at other hospitals, that we don't actually need more nurses just because we have more single rooms. But Dwayne, I'd be really interested in your view on that.
Thank you. And this question was from Alex Hickenbotham or Hickenbotham. And I'm sorry, Alex, I don't know how you pronounce your surname, so apologies if I got that wrong. That wasn't my intention. In your question, you said, with the planned Watford redevelopment to have 90% bed capacity as single bedrooms, we haven't actually done that, and I'm afraid that might have been my fault for not having a clear slide. What I was trying to say was that we're looking to rebuild 90% of the clinical accommodation on the Watford site. But as I said in the presentation, the number of single rooms will vary. So in intensive care and in paediatrics and in maternity, that will be 100%, because that's the guidance that we have, that that provides the best outcome for that patient group. Now, when you look at adult services, beyond that, there's a lot of evidence to suggest that 100% single rooms is not always advantageous, depending upon the patient group and also how sick the patient is. So what we're doing at the moment is looking very clearly at that patient group, mainly adult patients, to say, how sick is that patient likely to be? And what is the most appropriate number of single rooms for that sort of patient group? So at the moment, what we're saying for that group of patients, somewhere between 50 and 70% for single rooms, so not up towards 90. Now in Scotland, the government in Scotland has mandated 100%, and in the Republic of Ireland as well. In England, and in Wales, the minimum number of single rooms we can have is 50%. And that's been the guidance for quite some years now. Now, I've spent a lot of time looking at the evidence base that's out there, and it's a bit sketchy, I've got to say. But I've been looking at the evidence base out there, and I keep myself up to speed with what the evidence base is. As Louise said, there isn't any strong evidence that we can see so far that increasing the number of single rooms increases the number of staff. It depends very much more on how you can observe patients on a ward and how staff can communicate between each other. So looking at patient observation, there are a number of different ways in which you can provide patient observation in 4-bedded bays, and we would never in the hospital redevelopment go above a bay with more than 4 patients in. That's an absolute. But it's how you can monitor and observe patients in single rooms. And we'll look at this when we have specific SRGs for ward design and single room design. Is the design solution that we're looking at, which is a national design solution, is to ensure that there is an observation panel, which can be blanked out if people want privacy, to make sure that we can see patients in single rooms as nurses walk along and look in through individual rooms, with a mix of 4-bed bays, depending upon how sick the patient is and how much monitoring and observation that they need. Now, the other point about IT, one of the concerns in some of the wards that have had 100% single rooms, like Pembury in Kent, was how staff could contact each other. And one of the IT solutions that we're looking at is wearable badges, so that staff can contact each other very, very quickly if they require support from other staff. And also, sorry, excuse me, in those single rooms, how patients can contact staff more quickly and more effectively as well. And this is one of the lessons that we've learned from our partners at Chase Farm, is that if a patient wants something, quite rightly, they'll pull the alarm bell or press the button and say, and then wait for a member of staff to come along and say, what would you like? And the patient says, oh, a glass of water, please. And then the nurse or the healthcare assistant has to walk away and then might get stopped by something else going on before they can take that glass of water or whatever it is back to the patient. And one of the big stressors of patients is they don't know how long that's going to take. So some of the modern communication systems is, if a patient wants something in a single room, they can press the button, they can talk to a member of staff directly, unless they've got hearing difficulty, in which case a different arrangement will be made. And the member of staff can say, it's okay, Mr. Passman, I'll be there in 5 minutes with your glass of water. And that reduces the amount of stress that patients do have in not knowing how long it will take for a member of staff to get there. And to pick up Louise's last point around patient monitoring, this isn't a new technology. I went to visit a hospital in a different part of London, looking at patient monitoring. And so if a patient's vital signs were heading off, then the staff could make an intervention really, really quickly. And that also helps increase the number of single rooms. So I'm sorry that seemed like a really, really long explanation, but I thought it was a very important explanation to provide people with the assurance that increasing the number of single rooms is not going to degrade the quality of care, because it is a really, really important point.
Thank you very much, Dwayne. Thank you for that. So I'm going to just go back to some of the pre-submitted questions, and one was about St Albans City Hospital, and the question was about the minor injuries unit. So I'll just deal with that quickly because the unit is closed at the moment. So we've closed it temporarily. Just so you know, we are trying to keep St Albans City Hospital as a COVID-free site, as Dwayne said, which means that we are doing all we can to scale up as much surgery as we can at that site. So that is our absolute priority at the moment, to keep that site running so that people don't have backlogs in their treatment and aren't unduly delayed. People who do need urgent care can go to the Hemel Urgent Care Centre, Urgent Treatment Centre, or they can call NHS 111, or for anything really serious, it's 999. So important that people understand it is still closed. There are good reasons for that. It's under review all the time, but we're really trying to get our surgery back up and running and treat all of our patients as quickly as we can. I'll just go through another couple of questions that have come in. One is about the money that's coming to us from the government. Is it a grant or is it a loan? It's somewhere between the two. It's probably too complicated to explain here, but it is on our FAQs. So please have a look at the FAQs on our website. It's called Public Dividend Capital, and we do have to repay a percentage of it, but it's quite technical. So and the information is already out there. And another question here, which is about the football club, and we know that there are plans for the football club to use the car park on match days, and are they contributing to the build costs? So we are having discussions with them about the car park and how we establish a payment system. So they will be contributing. We haven't got it all ironed out yet, but we are in conversation with them. It's not a free good, although we like having them as neighbours for some reasons. We're not just going to let them take over the car park for free. So we are having those discussions with them. And another question on the car park was, where is it going to be? And at Watford, it is the land just below where the football club is, so sort of on the top of the slope there. And I know that the word slope worries some people, but please rest assured that you drive into the car park, and then in the car park will be lifts. So as a pedestrian, you should be able to come out on the floor that you need to be on for your treatment or to make a visit. So we hope that slope is going to be a thing of the past in terms of people having to walk up and down it. So there are some questions here about accommodation also in Riverwell. Joan, I'll just pick that up quickly for you if you don't mind. We do understand that there are housing schemes, mortgage schemes for all the property that's being built around us. So there's lots of opportunity to get support with buying properties on the Riverwell development. So we would hope that staff who want to work at the hospital can take advantage of those schemes. It's not quite a key worker scheme, but it is an intention to make local homes available at or with help. So Edie, I know, has some questions. So if we just come to you, Edie, and make sure that we can take you off mute and you can ask your question, and then we've also got a few more afterwards. So can you take yourself off mute, Edie? You should be able to. Just while Edie's doing that, I'm just going to, oh, here she is, brilliant. Okay, over to you, Edie, over to you.
Thank you very much. The first one I'd like to ask is the plans at the moment. Preferred option is 590 million, new hospital at Watford. What happens if you can't get that money? What is plan B? So what happens after that if you're refused?
So, sorry, Edie, I think in the interest of time, If you can just take that question first, Dwayne, and then we'll come back to some of the other questions. Thank you.
Well, Plan B, Edie, is the 2019 strategic outline case. So what we would look to do, if we don't get 590 million, and can I just remind you that 590 million is not just for Watford, 590 million is for Watford, St Albans, Hemel. So back in the strategic outline case in 2018, 2019, it was 390 million. So what we would have to do for 390 million is cut our cloth. And that sort of sum, we would still be investing at Hemel and St Albans because that's the commitment we made in the strategic outline case. It wouldn't allow us to replace Princess Michael of Kent.
You might need to explain that Princess Michael of Kent is a building, Dwayne.
Oh, I'm sorry. I didn't mean the person, although I've met her. No, the Princess Michael of Kent building, which although was opened in 1984-85, has not taken the test of time, really. So to be honest, Edie, it would be, we wouldn't be able to replace that.
Right. I mean, it is at the end of its life, and in fact, it was supposed to be at the end of its life back in 2013.
Well, to be perfectly honest, it was completed in 1984. It shouldn't be at the end of it life for 60 years after that.
I know,
which is shocking, to be perfectly honest.
Indeed.
What we would have to do is undertake a major refurbishment program within it, and that will be if you're able to access the pack that we put forward for the joint boards on the 1st of October, we did do an assessment around what that would mean inside Princess Michael of Kent wing to be able to do that, and it would be phenomenally difficult. It would be doable. It would be doable. Everything is doable. It would just be difficult.
And it wouldn't be good value for money. Can I also ask about your construction partner? Is that going out to tender? And also with the car park, who is it going to be run by? Who is going to own it? And who is paying for it?
Right, okay. So construction partner, we will be using what's called a government framework. So either the Crown Commercial Service Framework, or which is run by the Cabinet Office. So they have a list of contractors on there, major building contractors, who you go to with what's called an information pack, and then you have and they bring in responses for that. You wait and score them, and you select a preferred contractor who you can work with. Sorry, Edie.
It's a tendering process.
It's not quite a tendering process. It's more of a negotiation process with a preferred contractor. Now that's where we stand at the moment in terms of government policy. Government policy is to do that. Now, at the moment, we're in discussion with the Department of Health around how we actually approach the construction market. So it might be that it's all a series of direct tenders. And at the moment, I can't tell you. The next point is around the car park. Who's it going to be run by? I will have to come back to you on that one because that's still in discussion as to exactly how it's going to be managed. Who is it funded by? It's funded mainly by the NHS, but there is a contribution from the so-called local asset-backed vehicle, which is a joint venture between Kears and Watford Borough Council. So they've put in some money as well, but not directly. It's a complicated equation. and I don't want to mislead you. So if if you don't mind, Edie, I will set out this over the next few days exactly how it works, because it's a commercial and complicated discussion that is really tedious, to be honest. Is that okay? I'm sorry I haven't answered a couple of your questions there, but I did try.
Thank you, Dwayne. We do have some others that have also, a couple of actually that came in a little bit before. So one is about when I mentioned the Community Eye initiative, that the question was, are we or are services being outsourced to private providers? And the answer is yes and no. There are community social enterprise organisations, other parts of the NHS. So when we say that services are moving out into the community, it doesn't necessarily follow that they're being provided by private sector. Sometimes it's another, as I say, another part of the NHS or a social enterprise, and sometimes it is private in that it might be some local consultants who've set up their own business. So it's a whole mix, with the intention that services that don't need to come onto a hospital site aren't on a hospital site. So that was that question there. Just having a look to see if there are any other questions that have come in on the chat. Comments about single rooms. One of the findings of single rooms, which one of the participants has picked up on, is that they can be boring and lacking in social stimulation for patients, and we are aware of that. So when we do increase the percentage of single rooms, we will be looking at what other hospitals have done, because we do know that that is an issue, and we will also want to make sure that people have access to technology, their own TVs and other systems to keep themselves interested while they're staying with us. And of course, we'll be doing all we can to make sure the stay is as short as possible. I'm just checking to see if there are any other questions. Yes, we did have a question about problems that are encountered as we start the work, and if there are significant problems at Watford, would it have a detrimental impact on work at Hemel Hempstead or St Albans? Would it take more money from the other sites? So Dwayne, perhaps if you can give an insight onto how problem at one site might affect the other two.
Well, the problems that problems on one site affecting the other two, the answer is no. I'll be really clear about that, because my intention is to make sure that the building works at St Albans and Hemel start first. That would be my view, because we're spending 50 odd million pounds there. Those will be, you know, different contractors, different building contractors from the ones who work at Watford, and we can potentially do that quicker. You know, I need to get my regulators on board, so the mysterious NHSE and IDHSC and HMT, but my intention is to get that work happening more quickly, so that'll be fine. The other thing is, when we're looking at the Watford site, and there was very, very specific questions about asbestos, underground services and historical remains, we're already undertaking and will undertake more site surveys. And let's remember, you know, where some of the existing buildings are, that's already happened. So we already know that. We already know what's below the ground at the Women and Children's Block, Princess Michael of Kent, and all the other buildings. So that gives me slightly less concern. Those are probably famous last words. In terms of asbestos within existing buildings or under them, we're already undertaking a refresh. So doing again some of our asbestos surveys, and that'll happen in the next few months. In terms of sewers and underground services, we know where the main sewers are. So we've got a really clear picture of that. Underground artifacts. As part of our planning consent, what we will have to do is do a desktop survey of where we think things could be. So it might be whether there's Roman remains, unexploded bombs, anything else. But at least from the work that's been done there before, and we're not starting on a blank slate on this one. There's been surveys done on the Riverwell site, there's been surveys done on the Watford site, in and around the Women and Children's Block and Princess Michael of Kent Wing. So we've got a relatively good picture. You can never say never, but part of the capital cost that we have is the contingency that we have. So it's a contingency sum that's badged against all of those things so that we don't take money from elsewhere in the programme.
Thank you very much, Dwayne. Thanks for that. I'm going to rattle through a few questions that have come in. So one is about the judicial review. When do we expect to hear? We think by the end of November, if not early December. And the second part to that question is if we are guided to carry out consultation, or the judgment is that we should have taken out or conducted a public consultation, will it affect the time frame? We don't think it will. If we need to do consultation, we will do that in the next phase. We would be coming out to do a lot of engagement anyway, so we don't think it will actually push the whole timescale out. A few more queries about football, worried about the traffic. It won't be a free-for-all, the car park, so we will closely monitor the number of spaces that can be given. It will only be a small number. As you know, the football fans are encouraged very strongly to travel in by train, but we will work very hard with the football club. They are very aware that our needs are important. And of course, there is Thomas Sawyer Way, which has a stretch for just emergency ambulances only. So we do find that patients who need to get to us via blue light can do that. We know it has been poor in the past and difficult, but Thomas Sawyer Way has really changed things dramatically. Another question about phlebotomy, blood tests. That is a service that we want to put out into the community as soon as we can, really, so that people aren't coming to hospital sites for blood tests. So that's kind of work in progress. And there was one other question that I don't think I've oh, Mount Vernon, sorry, yes, Mount Vernon, it is 3 o'clock, but I should be very brief. Some of you are aware that there are discussions going on about the services at Mount Vernon. The decision, the clinical decision, is that those services should not remain on a standalone site, and a lot of those services should be linked to services at an acute site, so that patients have access to high dependency intensive care emergency services if they need it, and that they are at a site where lots of research is carried out. So that points to the Mount Vernon Cancer Centre moving most of its services to an acute hospital. 6 acute hospitals are likely to be mentioned in board papers coming up early next month, and we understand that we will be one of them. So we continue to work with colleagues at Mount Vernon as they go through their process to work out what will achieve the best clinical outcome for patients. And that's really all I can say on that topic at this stage. That's going to be a watch this space, but rest assured, we and other acutes are all very aware of the situation there, and we are all working together in the interests of the patients. So that does bring us to 1 minute past 3. We have another of these tomorrow, so if we didn't get round to your question or you have another question, you can either submit it and via email, and we'll answer it, or submit it via chat or by raising your hand in tomorrow's session. If you want to join us again, you're very welcome. So thank you very much for your time, everyone.